Good evening, sir. Sir, it's not audible.
Hello.
It's audible.
Hello.
Yes, sir.
Okay. I hope the screen is also visible or not.
No, sir, your screen is not visible. Now it's visible, sir.
All right, thank you. So it's more or less a repetition of what had been previously covered in our previous classes. Uh, the topic is navigating the moral challenges in healthcare leadership. It revolves around ethical problem solving in hospital administration, where people are getting challenged because of several options of decision making, whether it could be emotional decision or intellectual decision, or it could be decision based upon the longevity of people. So we'll start our today's class with the agenda, which involves ethical problem solving in hospital administration, resource allocation, and fair distribution under the scarcity of resources. The third topic would be patient autonomy versus administrative efficiency. So we'll have to see what is the basis of giving importance under a particular context. Then we'll also look into the volunteerism in healthcare, including ethical behavior of people, training of personnel and staffs, and boundaries applicable thereof. And eventually, as usual, we will have to touch upon the community participation, which involves ethical inclusion of all the local voices and the future directions of using technology and equity and data ethics for the overall governance of the hospitals. Um, and we can also see some of the practices which are relevant for the last class, because this is the week number 15 topic, which happens to be the last session, and concluding with the balancing of ethics and efficiency along with the patient trust. So ethical healthcare is normally possible only under constraints. Um, the staff is always trying to bridge the gap between institutional strategy of what the institution is likely to become and adopt in the coming years, and what kind of community action is required at that stage of development of the institution. Here, institution can refer to hospital, it can be referring to organizations or any healthcare units which are offering its services, and specifically under the non-profit organization category. So hospital administration involves a lot of complex decisions which involve and impact patient care and staff well-being as well. That having said, other stakeholders which demand community trust is also equally very much important. That's why ethical problem solving ensures that leadership choices are grounded in fairness. So there could be transformational leaderships at some end, there could be transaction leadership, there could be servant leadership. So under different contexts, maybe some leaderships are more prominent than others, but all the types of leaderships will be utilized in some way or the other, which has to ensure fairness in decision making, transparency in data collection procedures, and respect for human dignity. So, as healthcare systems are facing rising demands and also the limited resources which the organizations have, administrators have to balance competing values while taking decisions, which could affect their efficiency or which impacts the equity or it affects the patient autonomy. So these are the parameters within which they'll have to give attention to all the three things, whether it should be more of equity or less of efficiency or more of patient autonomy than anything else. So these are some of the factors which affect their decision making. This presentation explores the key ethical dilemmas which people face in this field and also the possible modern solutions in hospital management, emphasizing the importance of inclusive principled decision making in every aspect of care delivery. So, ethical leadership is not just an optional topic, but it becomes imperative to lay the foundation for a sustainable, trustworthy healthcare institutions of the future. So, ethical principles in resource is nothing but um, we are having limited ICU beds, limited number of ventilators at any given point of time. Medications are also scarce. Equivalent medicines are also available. So, in order to deal with this kind of limitations, we should also try to know that life saving care is of utmost importance because of emergencies down the line. So, some of the principles which we have already covered is justice, providing justice, and adopting beneficence in the interest of the patient, and non-malfeasance, not creating any harm to anyone. So fairness must be maintained without any discrimination, and patient outcomes must be prioritized over the administrative convenience. So since it is a very caretaking industry, administrative convenience has sometimes gets compromised. This process should be transparent, documented, and that's the reason why rationality at sometimes take over the emotional challenges while following the ethics committee to ensure the accountability. Another thing is practical strategies. So at any given point of time within these parameters, they have to mitigate the ethical dilemmas through standardized policies. So every hospital should come up with a clear and very detailed policy as to what decision has to be taken so that it becomes a guideline for procedures and practices to be followed. Clear triage protocols. So under the given context, what kind of decision making has to be taken with limited number of resources, and real time resource tracking has to be always be available at the disposal of this decision maker. So technology will come in handy, such as predictive analytics. It will help us to have the forecast demand and how much of resource allocation has to be done. Well, ethics committees also provide critical insights and oversights into what could be a more important. So transparent communication with patients and families builds the trust. So always there should be any kind of discussions and communication between the stakeholders of mainly the patients and their families, and the trust building is equally important, which reduces the conflict before any kind of action is taken. Like for instance, any kind of operation has to be there or any critical care is taken, before which communication is too much essential. In emergencies such as pandemics or pre-established guidelines ensure consistency and fairness across the diverse patient groups, because every patient has a different story to tell. So the core dilemma we arrive at is under severe constraints. Normally, when the demand for services expected from the hospital outpaces the supply, then clinical and operational decisions inevitably become moral dilemmas rather than remaining just clinical, because they are about governing the institutions along with the communities in which they are located. So the scale is becoming more important, especially when resource exhaustion forces life and death allocation decisions. So you will have two negatives or one positive decision and one negative, or there are two positives at some time. So, but which one has to be given top priority becomes a very challenging issue while taking decision, because of institutional constraints and the limits within which the patient is being catered for. Sometimes you have to refer to a higher hospital, a higher expert, or it has to be done with the telemedicine, or it has to be done with community support, or it requires additional allied or medical care facilities. At the same time, not disregarding the network, because it very much is part of a community, but also not to forget that community also has its own constraints within which underserved populations may face unfertilized capacity because of access problem. But they are willing people who want to avail the services, but unintegrated health volunteers are there. They may not know insurance, or they may have financial crunch, or they may be not having the knowledge what other people may be having. So that becomes sometimes inevitable decisions under which the network community constraints have to work under. Now, coming to which is a choice between a patient autonomy, in which patient decides what has to be received by him versus what has to be administered to the patient, that is administrative efficiency from the hospital's perspective. So balancing individual rights with systemic needs is one particular stage in which decisions have to be discussed much before any action could be taken. So, the value of patient choice. Patient autonomy is the right of the individuals to make informed decisions about their own treatment. This includes the right to accept or refuse the medical interventions, even if they go against the standard protocols. So, sometimes you must have seen doctor say something, nurse may not be aware about it, or even down the line, people who are helping them around the healthcare workers, they may not know that they are well aware about the standard protocols, but what patient is telling about them may not be equally known to all the people, especially when it comes down the line staff. So doctors may know what the patient really wants, but the other people in administrative positions may not really know the current situation of what the patient is undergoing. So respecting the autonomy is going to foster the trust and empowers patients to take the ownership of their health. So not just the hospital is responsible for the healthcare offered to them, but patients himself sometimes take the ownership of what has to be done along with him. So, however, when patient request unnecessary tests, so some people are there who request if something happens for a silly reason, also they might request for tests, and some other people want to deliberately delay the treatment as far as possible under different contexts. So it can strain the hospital resources, and the hospital is not sure whether the bills will be paid by the patient or relative, or it is going to be taken on credit, and it may disrupt the care flow in between. So something of what has to be known previously will come up at a later stage. So the role of shared decision making becomes all the more important. Administrative people who are in good positions should ensure that hospitals operate smoothly, reducing the costs and waiting times. Efficient operations allow for better service delivery and staff well-being. Yet the overemphasizing efficiency may compromise patient care or lead to decisions that violate the ethical standards. So, shared decision making bridges the gap by involving patients in discussions about risks, benefits, and alternatives. So, in any decision, there could be risks, there could be a limited number of benefits, but there are more alternatives because of advancement of technology. So, we have to see the risks associated for any decision, benefits associated by undergoing and by recommending a particular uh, pathway of treatment and alternatives which is offered to the patient. So what we see are basically the four pillars again, which we had studied in the last class. That is beneficence, acting in the best interest of others, and promoting the well-being of the patient, so that it is beneficial for the person who is undergoing the treatment. Non-malfeasance, doing no harm or acting to avoid harm. This is another pillar on which the medical ethics and the community or the fraternity of medical ethics is based upon. Another pillar is autonomy, giving respect about self determination, respecting the patient rights to make his or her own choices. And finally, the justice, which is being another pillar, which is nothing but treating people fairly, impartially, and equitably. So, under normal circumstances, the physician relationship is intuitively guided. But these days, because of intervention of technology, it is not just IQ question or EQ question, but it is a principle of moral ethics, which is also affected by technological advancements. So, in such conditions, volunteerism is also required in healthcare. People who voluntarily bridge the gap between what has been trained to the staff, what the organization consists itself in terms of the boundaries which they have set forth for themselves, and the ethical pathway which is there in front of them. So volunteerism is always a vital role which is expanding access to the healthcare people, especially in rural areas, because without voluntarily dedicated number of staff, there are very many underserved communities which may not actually get the benefit of various schemes which uh, the government in place is trying to offer, as well as the non-profit organizations is trying to offer. So volunteers in large numbers assist in health camps, vaccination drives, awareness campaigns, and improving the public health outreach, because the doctors are the last ones to actually go for marketing. They are far away from marketing their services, but there should be volunteers who should be able to vouch and attest that endorse the services of the non-profitable organization. And however, ethical concerns are also arising when volunteers lack proper medical training. People may find little bit scary, or sometimes they may not be able to take a good judgment if the data is not there in the public domain, or they have nothing to verify about the outcomes, or they don't have the reviews so far, or they may not have been conversant with a lot of things what is happening in a larger city, especially if the people are the rural folks and underserved communities. So they normally blindly believe and sincerely undergo all the treatment. But if most of the things are not within the boundaries, or other organizations are unnecessarily imposing their profit orientation. So one has to have always a clear boundaries of knowing why volunteerism is supported, why people are supporting these kind of services, and how supervision has to be done and governance has to be done along with ethical guidelines, which is essentially for the benefit of the patient safety and maintain professional standards in the healthcare. So training programs must also emphasize beneficence, non-malfeasance, cultural sensitivity to uphold the integrity of volunteer services. Then we have got the paradigm shift. So under normal circumstances, people may not normally question various things which doctors are doing. They normally believe, but under crisis conditions, the ethics altogether takes a different turn. Especially during disasters, ethical principles still exist, but their application fundamentally pivots from individual to the population. So more than individual, population becomes important, because the entirety of how healthcare services have been delivered becomes questionable. So in the under the normal state, individual well-being is there. Focus solely is on the well-being of one person and autonomy of individual patients. But abundant resources allow all the requests to be considered. So normally, hospital is in a condition whereby it can offer multiple services, but under a different situation in the context of crisis, population survival becomes the center stage, and it takes the whole population precedence over the individual requirements. So the use of resources for one patient may mean the denial of resources for another, because there are a group of people who have to receive the treatment. So in all, we should ensure that empowering communities becomes too valuable for anybody to undertake any kind of decision making, including the local voices have to be heard. And healthcare decisions are not just taken individually, especially during crisis situations, but it's all about managing how well the scarce resources allocation strategies are well managed. So no, there is no single ethical value that you can perfectly dictate that this is a good way to go ahead with. There are various factors of combination permutations of triage strategy, which includes distinct moral trade-offs. So it's always a trade-off between what are limited in a hospital, what the patient is saying, what the justice is offering, and what are the critical limitations under the given context. Especially mm, when you say the core philosophy is saving most of the lives. If your hospital believes that saving most of the lives under the pandemic, or saving most life years is concerned, the allocation strategy would be maximizing the benefits for all. And the critical limitation would be disfavoring the elderly, because when you're focusing on the entirety of the community members, naturally the elders are getting sidelined, because it ignores the equitable distribution of life years. Similarly, under another, if the core philosophy is first come first serve basis, or if anybody is coming first, who he has to be treated, if that's what the policy of the hospital is, or even into the lottery system, then allocation strategy would also involve treating the people equally. Instead of maximizing the benefit for some, you will have to treat all the people equally, and then the critical limitations under this condition will be favors the privileged populations, those whose disposable income is more, who can afford, who can travel and access the information quickly. They are the ones who are getting the first come first served basis of accessing the services. And if the core philosophy is prioritizing the essential personnel, example, ICU staff members, the scientists who actively combat the crisis, then rewarding those people with the instrumental value becomes essential, because you are prioritizing essential people and who actively combating, who are the forefront of fighting and combating the disease. It requires strict separation of direct pandemic utility from subjective social value. So society may be seeing it subjectively, but there requires a strict line of separation of direct pandemic utility and how you reward the instrumental value. For instance, there was a huge cry when vaccines were not invented, but people were very happy in order to prioritize the essential services to a few. In fact, there were a lot many companies who can drop the doctors to the hospital, get them back from the hospital, and cabs were introduced, and strict norms of various rules and regulations were given. So more than utility is, people will see the subjective social value, how it is going to alter the entire population's course of action. Then, in case if the core philosophy is to treat the sickest first, if you want to treat the sickest person first, then allocation strategy will be prioritizing the worst of people. You have to give importance to the worst of people first, and then ethical limitation would be it consumes vast amount of resources on patients with poor prognosis and depriving others who could survive. So here and there could be limitations and trade-offs under different allocation strategy and different which believes in a certain philosophy, and limitations are there for every step under the allocation of resources. So these are the parameters that there is no single ethical value that can perfectly dictate how the things have to be distributed. Every triage strategy consists of distinct moral trade-offs and critical limitations as well. So again and again, needless to say that community ensures that everything is smoothly running. So community participation ensures that healthcare programs reflect the local needs. People know the beliefs and cultural practices locally. When communities are involved in planning and implementation, services become more relevant and accessible. Local knowledge helps them to identify the barriers. So people may not be very familiar. Outside people who are trying to give suggestions or recommendation prescriptions, they may not know the local stigma attached with certain practices, or the local language, or the transportation issues, how people go and come, and how many times this goes on. So they may not know the predictability in case of sensitivities. So this leads to community involvement, which requires effective, sustainable, and equitable health outcomes. That's why volunteerism is equally important, alongside building trust through including all the people. So, social inclusion, ethical challenges include representation of marginalized groups and preventing decision making power from being concentrated in a few people. So, most of the people should be involved, all the stakeholders should be involved. Inclusive process requires transparency, active listening, and shared decision making. And these healthcare providers must ensure that they respect the local cultural values and avoid imposing external models on the local population. So, over a period of time, people will get used to why trust is important before uh, organizing anything, because it is a trust which is driving factor. It is inclusion which is going to make sure that things are running smoothly. So, you can see that in order to develop trust, there should be transparency, and clinical triage teams have to be formed, that which is the best course of action. Frontline providers should never be forced to make resource allocation. So those who are actually combating and who are the frontline, they are not the ones who can have the final say in terms of resource allocation on their own patients, but the frontline care is always engaged for, because he's emotionally investing his time and focusing strictly time, money, effort, dedication on direct patient care and one-to-one conversation. The higher level passes the allocation dilemma forward. Someone else down the line in the administrative field, they can take the call, and clinical triage teams are formed in which the objective evaluation has to take the lead. There should be some rationality, some reasonability, and reasonable decision making, which applies multi-value allocation frameworks, and it has to be measured, because what gets measured gets easily implemented. So it reduces the conflict of interest between one who is providing, otherwise the doctor will be the receiving end. In some states, you must have come across that doctors are the ones who are getting severely treated by the societies in case the outcomes are not favorable to the patient. But given the kind of domain in which people are working, there are risks associated. The clinical triage teams have to be formed, and which should ideally lead to the public trust. So this is what is important under any circumstance. So it should ensure that frequent, honest, and transparent communication is enabled. So this should uh, have some kind of consolation for the grieving families and people regarding their altered case standards. They should not doubt the precedence with which the decisions have to be taken, and there should be some way intermediary who has to manage everything rather than leaving it for the media people to overpower any kind of decisions. So it is under stress that these decisions are taken. So public trust assumes a lot of responsibility for giving back to the society what the frontline care provider may actually not have that much of time in order to think about the entirety of the organization, because he's more strictly focusing on direct patient care rather than thinking on various terms. So future directions is utilization of technology, which can be used for betterment of decision making, equity, and also data ethics. The future of hospital administration will be shaped by rapid technological advances. So any kind of scientific advancement in artificial intelligence, electronic health records, and telemedicine will become more powerful in the coming days and years, which introduces new ethical challenges. Data privacy assumed because of DPDP Act. There's only one or two people who will be held responsible for whatever data is coming into the organization and whatever data is outgoing from the organization. Algorithmic bias, someone has to become responsible and accountable to have the digital access, so that disparities must be addressed to ensure that equitable care has been taken for all the people concerned. So ethical frameworks must involve to govern the use of AI in diagnosis. So treatment recommendations and resource allocation. Hospitals must prioritize transparency, informed consent, and all these documentations along with the patient rights, with signatures, with digital signatures, with passwords, or sometimes barcodes. Each and everything has to be taken for the digital initiatives to maintain trust and uphold the ethical standards. So modern tools, let's have a little bit of what leadership people in leadership positions have to take a call while having contemporary and advanced practices. So structured ethical models is what is required in practice. So most of all, the policies, procedures, practices, processes, all of them have to have some ethical dimension in which decision making framework is taken, and four-step model to guide the administrator through complex dilemmas. People every now and then they go through these complex dilemmas. These models identify the issue at hand, gather the relevant factors which are applicable and influence at that time, apply the ethical principles, and evaluate the outcomes. So input, output, and outcomes, all the three things will come into play, and ethical committees will have to be formed, which provide the expert guidance. In some cases, external experts and neutral people also have to be referred to, because we cannot blindly accept what the hospital or single person is telling, no matter how expert he is, because while clinical consultations may be costly over a period of time, but that support real time decisions involving patients and families. So this brings to making this healthcare all the more interdisciplinary and data driven ethics, in which the formal decision making is not just in the hands of there's the patient as well as the doctor, who are of course at the core of it, but then advanced approaches including interdisciplinary teams, triage teams, data analytics teams, AI driven simulations. So you can have simulation which can make sure that the predictive analytics, and you are able to have what will be the good situation or moderate situation or worst of situations. These predictive models can assess the patient risk profiles and support the fair triage decisions. So ethical leadership is what they have to support by embedding in the organizational culture itself. So when ethical leadership becomes a part of the organizational culture, and when regular training of the staff becomes important, taking consent becomes normal, having an equity in terms of distributions is becoming usual, and conflict resolution is regularly followed up. So these practices promote accountability and improve patient centered outcomes. So you can have a balance or trade-off between autonomy and efficiency. So people are running behind efficiency like anything these days, but we forget once in a while that autonomy is equally important. What patient is saying is equally important. So administrators must constantly negotiate the tension between the patient right to choose what he wants and what doesn't he want, what the hospital wants and what and the hospital may not want. So it is always in a perplex condition in which hospitals need to serve the maximum number of people on one hand. However, patient autonomy also given equal importance of customized treatment plans, request for diagnostic tests, how many tests the person wants to undergo, right to refuse care equally has to be given emphasis, and longer decision times which may alter the entire course of action. So patient autonomy is something on one hand which you have to trade off while decision making alongside the administrative efficiency which people are more fond of, because being a professional their concentration is always on cost control metrics. They have to also understand the reduced wait times. They can also standardize the care protocols and maximize the bed turnover at the same time. So challenging issues between patient autonomy and administrative efficiency, with what level of care and what kind of protocol are they able to maintain all these things, is nothing but a shared decision making scenario in which ethics committees are formed, and ethics committee have to take a balanced trade-off between these two variables which are all the time active. So the path forward for ethical hospital administration is nothing but balancing these issues of ethics, efficiency, and trust. So, at one point of time, all the three are active, in which people have to come to conclusion what is right now more important in the under the given case, and eventually, in order to help all those things, we have to have micro level public healthcare units as far as non-private is concerned, because the NPO, in case of NPO, and the overall idea is to alleviate institutional strain. No individual organization should undergo a severe strain, especially when there is a lot of demand in a particular area. Healthcare delivery must extend beyond the hospital walls. So we are not limited to the building per se. We are not restricting ourselves that only people have to come all the time to the particular hospital wall in order to get taken care. But then there are self-help groups, the help of whom have to be taken. There are individual health volunteers who have to be given, lot of association along with the coordination and cooperation with these kind of people who are assisting the entire structure of the organization. And alongside, nevertheless, rural healthcare centers are there, and we have the panchayati raj institutions. So this is where the shift of community, the place in which the hospital is located, is not somewhere located in the sky or some top of the mountain. Hospital is very much a part of the entire society, and whoever are there in the society, give and take between the members has to be encouraged. That's how the care will be nurtured along the way. But there are some issues. There's a catch in it, that not necessarily that all the motivated community members will end up getting equal response, because health volunteers act as the vital link. There are volunteers who are acting between the society and the health system, but the potential is severely diminished, sometimes by the structural neglect of the entire system. Because where they are likely to get neglected, one, role confusion. So the always amount of confusion doing affairs without clear planning is it. So in the management we call planning, organizing, directing, controlling. Sometimes the planning goes wrong, obviously the subsequent steps may also go wrong. So it may not happen that 100% everything is going right. There could be inefficient training or improper training, or people may not know certain actions which are only lecture based but not demonstration based, or they have the lacking the skill what is required in a particular, let us say, domain. So over a period of time, there are unfertilized capacity in which motivated community members are there, but they have not been taken care, because it's largely unknown to the public. People are not familiar okay, with the volunteer names or activities. Some newcomers are there. There are people who are leaving also, and there's no strict formulation of feedback. So there is a lack of feedback, and there's a weaker communication and instruction. So all this may hamper in giving us some unfertilized capacity. So all these, despite having a lot of community members who are ready to offer the services, we end up having unfertilized capacity, a fraction of the realized healthcare value. So one has to know under what context these get filtered automatically in order to overcome the burden on some people who are more active than others. So the key takeaways for the hospital administrator is one: ethical problem solving is not just a moral obligation; it is a strategic necessity. It's not that you are obliged to do everything what every person is telling, but it's the team which has to know the coordination, cooperation, and it is a strategy which has to be followed. And administrators, they should integrate the ethical principles into the daily operations, because unless it becomes a habit, unless it is remaining only in the books and never being trained, and unless people are inclusively included in all the decision making, there is no point in simply training and going ahead, because training is half of the work done. Remaining processes, involvement of people is most important. Balancing the patient autonomy with administrative efficiency is very critical. At the same time, what community says, how community sees it, what is the perspective of the community, and how humility and collaboration is all the more important all the time. And commitment to justice is becoming imperative for the global healthcare workers. Because of commitment to justice, people are taking severe actions, sometimes on the healthcare workers, sometimes on the doctors, sometimes on the staff members. So commitment to justice is essential, not without humility and collaboration, but with excessive care. So at the same time, without any disregard to the technology which is evolving parallelly, we should have the ethical frameworks, because it is the humans which are finally prioritizing the equity, accountability, trust. AI may come up with any solution, but that doesn't mean that intermediary decisions have to be taken only by AI. It has to be done with human interventions, and high quality care has to be given to them. But also, a healthcare system should reflect the values of the communities where it is serving. Something which is applicable in one area may not be applicable in another area because of severe constraints of the communities or belief systems of communities. So the takeaway for hospital administrators: they should know the local culture, they should be sensitive to the local culture, they should know the evolving technology, they should also know the laws of the land, they should know what is commitment to justice, what is volunteerism, why people are volunteering under those conditions, why people have to give respect to all the stakeholders and not only to the doctors and patients involved, but to the entire community at large. So hospital administrators, day in and day out, they should integrate the ethical principles in order to have the daily operations sail through the transparent policies. So one is to reduce this confusion of ethical framework by clear role definition, that is job description and job specifications of the strict boundaries within which they are working, and there should be professional staff members and volunteers. Second, learner centric training has to be given, not hospital centric or doctor centric training, not even patient centric. Whether the learner is able to learn effectively everything, so it is that which is not just a passive lecture, or it is not a systematic recorded lecture or something like that, but it is a localized skill building capability. The skills have to be built over a period of time. It cannot be built within 1 month or 2 months. It has to go along with 2 to 3 months, and how to go along with DMLT, X-ray, various scanning, blood pressure monitoring, personalized care, each and every smaller things which thereof, which has to be given attention to. And then third is support and feedback. So building social capital is one thing, but consistently building it with under supervision and sometimes without supervision also is equally important, because community recognition is more important at the end for the hospital to become a benchmark in having a respectable and respectful feedback loops, because it is a part of the society in which it operates. Support and feedback is equally important. So volunteerism is only the ethical and effective when it is going to have the commitment to proper training. And when there is commitment to proper training, role boundaries are very clear and continuous support is there. then it has some meaning in which the synchronization of all the units will happen, so that the funnel is all the more understood, particularly by the voluntary management systems and not just the experts. And there could be participatory learning. So what PLA stands for is known as participatory learning action. So everybody have to participate. Step one is orientation, engaging the local self-help groups, the Asha communities, the primary groups, the self-help groups, all these community members is nothing but orientation under particular policy, procedure, practice, and process. So step one is orientation. Step two is facilitation. So you should have some incentivization to give them exercises and local situations without outside interference. So it should be done within the local community. Facilitation has to be improved. Then comes the dissemination of knowledge, scientific dissemination of knowledge, presenting the findings to the broader village, and make it a habit for them to share every now and then, maybe weekly or quarterly, sometimes, so that the feedback and building consensus is receiving more credibility. So building the consensus so that everybody is informed, that is most important for the community. Longer range goals, and active owners of the local health solutions have to be gaining ground. So over a period of time, action has to be taken. So what is action? Translating the group learning. Okay, all are learning, that's the different issue, but translating the group learning into localized sustainable health intervention. So it should be the sustainability always that has to go over a long period of time. So empowering these communities with a participatory learning action is the only way, so that these passive recipients of healthcare will become the active owners of their own solutions. And the if the particular community is facing the ownership, even the solution should come from that community itself. So we can't hunt a foreign person to find problems which is very much local. So it should be grounded in the reality with grassroots level people working all the time in order to ensure that participatory learning action happens systematically and it is sustainable. And second thing in participatory learning action is diagnosing the enablers and barriers. We should not only know the barriers on one hand, but obviously enablers. There is a you have the Anganwadi centers, we have the sub centers. They have got gardeners. The kitchen gardens are also there for organic growing of something like for some kind of supplies. Then you got the school facilities wherein all the vaccination drives or polio vaccination, DPT, and all those things have to be nearby. They are the enablers, in fact. And once the drive is undertaken, there are self-help groups which are in the local community. They will come and support all these kind of enablement of community driven decision making. And existing health schemes have to be understood thoroughly. Most of the times, whatever government is doing, half of the people are not utilizing what the government is giving it, whether it's central government or state government. Half of the schemes are not known by many because the volunteers may not be fully trained. Okay, people have the schemes but they have not been trained. So but there are enablers. At the same time, there are barriers also. So as we all know, in India, people are prone to some kind of getting affected due to alcohol, addicted to tobacco is another. So, and one more problem is with the unemployment or part-time employment, or sometimes with the passive employment, or you can say pseudo employment kind of a thing, underemployment. So poverty is also there. So these become troublesome, for us to work smoothly. And poor transportation once in a while and roads not under good conditions, that becomes a problem. Another problem is quality of drinking water, and whether transportation of water from one area to another area, all that becomes a problem. Another is open defecation. So in certain cities, people don't have toilets and all, so that is yet another problem. And lack of hospital facilities. So these are some of the areas which are nothing but barriers to achieving the goal. But there are positive factors which keep on helping us in order to drive home the community support. So if you take the learning action ahead, so we have to have a mapping of the entirety what we have. Where is the school? Where is the religious area in which worshipping is done. Where are the Anganwadi workers? Where is the pond? Where is the house? Okay, how far the pond is there? How much of struggle and hardships people are undergoing? Okay, all this resource mapping can be done on one hand, and the now action, the sooner action, and the later action, the NSL action. And so the NSL actions, what has to be done within 3 months, then what can be done from within 3 months to 1 year, and then later what can be done in the upcoming near future, like 1 year or 2 year period, what can be done. So within 3 months, we always know we have to keep our areas neat and clean, cleaning of and draining of regularly the systems in which people are living, restarting the adolescent health days, and understanding the maternal meetings. So these are some of the activities which people or volunteers will take care, and awareness campaigns against alcohol abuse and addiction, any kind of addiction it could be. So it could be drug addiction, it could be alcohol addiction, it could be addiction to even, let us say, social media. And then improve the sanitary napkin access and providing the machine to give and issue those sanitary napkin access. So what has to be achieved is stage by stage, the NSL action, the now action, the sooner action, the later year actions, they should collaborate with the NGOs, and these NGOs and POs will have to improve the long-term infrastructure in which you are able to have the course of action, in which the resource mapping, how it was done in a better way. The future has to ensure that all this action planning is done, from planning, organizing, directing, controlling the supervisors, volunteering for the cause, and understanding the schemes which is already there in place. So it brings us down to one thing, so future directions. So one thing is for sure that technology is changing. Artificial intelligence is used for diagnosis. Electronic health records are maintained, and cybersecurity is becoming a challenge in order to prevent data leakage. So ethics in technology is becoming attracting a lot of attention these days. Then comes your data privacy. So whether any other hospital is behind your hospital and trying to steal the digital access and patient data, that becomes a challenge. So there should be one or two people who are specifically dedicated for protecting this data. Then comes your shifting demographics. As we all know that uh, there are aging populations, there are younger populations, but some populations are not having the same kind of health and living conditions. There could be chronic diseases which the areas may be facing, in due to which people are leaving their leaving behind their livelihoods in one place, and they are moving ahead with migrant populations. So shifting demographics is also one thing which one has to be really careful about for future directions and giving prescriptions and recommendations. And finally, global health equity. So, preparing for global health emergencies and systemic healthcare inequalities. So, we have to be ready for whatever the future holds for us. We have to find out how the health emergencies are cropping up and what kind of systemic healthcare inequalities are gaining because of sudden change in kind of climate conditions, or global warming, or any kind of sustainable development SDG goals which the United Nations have come up. So global health equity is something at the global level what people are really monitoring upon. That is also equally important. That system sustainable development goals of the United Nations also equally becomes important. So on one hand, technology is changing. On the other hand, data privacy becomes too sure for us to comply with. Then shifting of demographics is gaining ground in some places, and then global health equity is another parameter which is going to dictate the data driven decision making which the healthcare people have to be conversant with. So we'll see this integrated ethical healthcare model, in which on one hand we are having the data driven matrix protocols and community ethics committees are formed, ethical committees for justice, and then resource allocation. So once this resource allocation is limited, then becomes a challenge for the scaling of hospitals. Whether the hospital wants to open another unit, whether clinical triage teams have been formed, how many clinical triage for the pre-opening of the hospitals, what kind of transparency they are able to manage within these policies, and ethical teams committees have the variation in terms of policy and governance frameworks, how it is working at a local level how precisely the flow diagrams and flow of the people are being taken care, and you are going to establish these kind of governance frameworks. And then comes your health volunteers on one. So health volunteers, we should also have uh, the learning action. So participatory learning action has to be given for the health workers. They cannot be left alone. They are the ones who are going to disseminate the information. They are the ones who are going to drive your campaigns. They are the ones who can prevent the health from falling apart. So data driven reallocation matrices and making duty rota, then data driven community needs assessment has to be done. What kind of needs are there for the given area? Then resource mapping in that stage will help us to overcome the barriers. So data reallocation matrices, preventive health campaigns have to be undertaken. So it's a give and take between whenever the company or the organization is willing to expand in certain areas, and how the network can be expanded by taking the assistance of participatory learning actions with the available health volunteers. So this gives a broad understanding of how ethical dilemmas can be overcome and in a resource driven or resource crunch areas, whereby we can have a policy in which some models will help us out in order to drive seamless allocation of healthcare for all the people concerned. So in all, we have seen one thing. We have understood four pillars: beneficence, justice, autonomy, malfeasance, non-malfeasance. Then we have understood what is ethical resilience. So ethical resilience is intertwining ethics with the moral ability and championing the cause of voluntary actions along with the organization, so that the strengthening the community and voluntary impact is taken seriously by all, and addressing the unfertilized capacity, why people are not availing the services despite the schemes being available, often struggling with the role confusion sometimes whether to do or not to do with a particular actionable insight. So insufficient training, sometimes leaving their unpotential, I mean, the leaving the potential untapped. Another thing we have touched upon is the participatory learning action, in which community has to analyze and take realistic time-bound action. And we have the clinical triage teams, which are going to determine who receives what level of service or higher level of service, whether the level of service has to be improved or it has to be moderated or it is to be uniform. That has to be taken by the clinical triage teams. And in case if there is a pandemic pivot, whenever individual rights are superseded by what is affecting the society at that time, how much of resources we have to give importance to what kind of patients. And finally, transparency, which maintains trust. So frequent honest communication ensures that public understand and support the difficult trial decisions, so that they will not go against one another. So transparency maintains the trust. We should always realize that transparency is more important in this given field. And strategy, one, if it is to save the most lives, what kind of core values you have. It's about saving the life years, then what kind of core values it is affected, highest affected number of years how to be saved. And if the strategy is to have importance, the instrumental value is sometimes like vaccination, which is not yet invented, all those things. Then what kind of the core value we are following, that prioritizing the care for essential workers to maintain a functional pandemic response framework or the workforce in which we are working. So these are the strategies and core values which are touched upon just now. And now coming to question and answer. Let's try to answer some of the questions. What is a primary ethical principle guiding fair distribution of limited healthcare resources? How, what is what one? C, okay. So justice, yes. It's not profit maximization. It's not just patient autonomy. If you're talking about fair distribution, it is about justice. Yes, that's the correct answer. Yes, thank you for answering. So why? Because fair distribution is nothing but non-discriminatory distribution. It's all about justice. Next comes most important factor in a ICU allocation. When ICUs are allocated to people, whether it is on the basis of wealth or it is basis on stay length, how many people days, how many times days he is always staying in hospital, or says recovery probability and age. So see, people are telling, see, nice. Let's see the answer. Yes, it's a recovery probability, prioritizing the highest survival chances. Next is conflict between autonomy and efficiency. When the person says, when the patient says he is the one who's going to decide, so can it be done for an extra MRI, or can is it about here the patient is taking refusing the ventilator? In fact, sometimes he doesn't want a ventilator, and says agree the treatment for whatever it is, or the conflict is only because of the delaying decisions. Yeah, some people are telling B. Let's see. Yes, because patients sometimes suddenly says he doesn't want ventilator. Okay, so patients can refuse. Despite everything being available, still the patient is saying I don't want ventilators. So it's about autonomy and efficiency. So patients can refuse the treatment, and we have to give respect to that patient. If he doesn't want ventilator, fair enough. There's nothing wrong with that. Next, concern about healthcare volunteers. So healthcare volunteers are always trained, or they have the lack of training, or it is done because of reducing the cost, or it is to increase the trust. What kind of concern we have almost always with the healthcare volunteers? Yes, people are coming with answer B, B, B. Yes. So it's about lack of training. Most often than not, we come across people who are lack the basic understanding of the concept. So training, lack of training, people have to take up the cause and start training them. So untrained volunteers risk the patient safety because they may not know everything what the patient requires physically. Then comes the community participation in improves ethics. How does the community participation is improving the ethics? So whether it helps us to reduce the beds, whether community participation is giving us more in value in terms of cultural relevance in which we are working, or it removes the communities, or it is increasing the profit. Yes, so community participation, obviously B is the right answer. Those who are told B are right. So community participation is nothing but staying relevant to the culture in which the hospital is located, and communities only can come to conclusion that it ensures that what kind of care fits the local needs. Under local needs, what is best, that is most important, not something who's super rich and what he's getting treated in the same way the local person who, despite having not having not a lot of money, then he is to be treated. So there should be some mediator effect because of this people, which is staying relevant as far as community participation is concerned. Then technology roles in ethics. So how this is going to solve the problem? It is going to remove the judgment once for all, or it is about improving the transparency, or it is to eliminate the dilemma, or it is to increase the autonomy of the people. Yes. So what we have to look in a technology role, actually we have to see it from the transparency point of view. So the technology is making our things more transparent, so people are knowing more, and improvement in knowing the ethics, the decision making, the rationale or the reasonableness of the context, that has to be transparent so that people will not question that it has been done with some other intention. So it helps for fair tracking of the decisions. Next is principle for patient's best interest. So, which of these principles is keeping in view the patient's best interest? Is it non-malfeasance? Is it beneficence? Is it justice? Or is it autonomy? Yes. People who are told B are the correct ones. So, beneficence promotes the patient well-being. That's one of the pillars under which we are working. Next comes strategy for ethical challenge. So, what kind of strategy for ethical challenges to handle? A, preferences only. B, ethics committees have to be formed. C, income priority. Or D, admin only. Yes, I suppose it should be B. Those who answered B, yes, ethics committees, because that has to be collective decision making, and it can happen for ensuring the fair decision, not affected by one person or two people, but the committees have to collectively take a decision. Then comes your AI ethical concern is what? What is the basic trouble with this one? There is no risk with AI, or it is a reduced bias, or it is a bias risk which people are worried about, or no oversight. Yes. So let's see the answer. Yes, you are right. The bias risk. So AI may reinforce inequalities. So we doubt it, seriously, we doubt it once in a while because it gives 2 to 3 responses. If you like it, you go ahead with one. And if you dislike, then it will give you another answer, which you can favorite answer, then you go a different course of action. So it's a bias risk always, which course of action one has to take. So next is benefit of shared decision making. So what's ultimately why this decision making have to be always be shared? One, it's going to reduce your costs. It's going to improve the trust. It is about speeding up the entire things, or it is removing the committees. Okay, B seems to be the answer. People are telling B, so let's see. Yes, it's about what? Improving the trust. So shared decision making is nothing but it is going to help us to improve trust in the system. So the system is ready, and its system has to give you the satisfaction and collaboration. Then only something meaningful can happen out of all this. So you can copy this in case if copying is possible. I'll try to. I mean, it's not. It's just a what do you call? Just another set of questions. Nothing else. Nothing. It's going somewhere else. What's happening here? How can I copy? Whether it can be copied at all in the first place or not. Anyway, more than this, there's nothing but poll questions. Okay, don't worry about all this. So additional 4 to 5 questions are there. Nothing much. Next is the question bank. So what I'll do is I'll copy here. Then come back.
Sir, can you share the PPT? It has not been shared from April 9. The last PPT we got
Okay.
only in April 9.
All right. Right now, what I'll do, I'll first give you the question and answer right now, which has, I suppose, which is even prioritized as far as your preparation of exam is concerned. So kindly click on this drive and let me know if you are able to download these questions. I'll share the PPT nevertheless, but just try to see if.
Yes, sir, we are able to download it.
Okay, sir.
Huh?
We are able to download the QB, sir.
You are able to download, right? Yeah. And another, in case if you have, then probably you can catch me on the LinkedIn. You can scan this or just take a screenshot of this one. In case if previous PPTs are there, then I can share because I don't have the WhatsApp. I can share on this as well in the LinkedIn. So you need to type my email ID for getting connected on the LinkedIn. I hope everybody has taken the screenshot. these two PPTs, I'll make sure that the entire thing is sent. One more class we have, because this question and answer were more important. Questions were more important than the PPT itself. But once it gets recorded, I'll be able to share this in the coming days.
Sir, as far in say this is a last class according to SRM's portal.
No,
This is the last class for GH.
but sir, but I suppose there's one more class on scheduled, which was cancelled on the day of Tamil Nadu
Elec-
elections. So 23rd has been
Yes, sir. They have posted in the Telegram saying there will be a class, that postponed
on
class.
Sunday, right?
Yes, sir.
Yeah. So Sunday, I suppose one more class is there. That's why. But nevertheless, I should have been sharing these questions on Sunday. But still, I am making, because some of them have the doubt, so I have shared it today only. This questions ABC part. But any PPTs are there, no? That I'll share together so that I can download some of the people together. I'll be able to share that. That's why I've given, on the safer side, I'm giving the LinkedIn as well. So there's some communication in between. Fine. Thank you, everybody.
Thank
Have a nice
you,
time.